So going to continue with our Mrcp PACES consultation session, and today I'm going to talk a bit about the SLE. So as usual, we're going to start our presentation and we're going to start with the history. So we have this 25-year-old Asian female, and she presents with worsening small joint pain and a new facial rash which flared after a trip to the beach on a hot and sunny day. She also reported recent multiple mouth ulcers, increased hair loss, and very dry eyes and mouth. So these are the features which you have to ask in any patient who presents with joint pain, especially the young female, because we'll be thinking about the connective tissue disorders, and the young female will also be thinking about the SLE. Now, remember that the onset of SLE is most typically between the ages of 15 and 44, and this is an actually age group where disease-related complications, they have a major life impact, encompassing physical, psychosocial, and reproductive consequences. Patients of non-Caucasian background, including Asians and Africans, typically have higher rates of SLE and more severe disease phenotypes, including high rates of lupus nephritis. Females are much more likely to be affected by SLE with a 9:1 female to male ratio. It is postulated that hormonal and X chromosome influences underlie this sex predominance. Now remember that joint pain is common in SLE, affecting 90% of the patient, and a typical pattern of joint pain in the SLE is symmetrical arthralgia of the hands, wrist, knee, ankles, and feet. Patient often has inflammatory characteristics, that is, symptoms are worse in the morning and associated stiffness and improvement with movement, and it can be migratory. Remember, in SLE, there are broad range of cutaneous manifestations. The most commonly seen include typical malar rash, subacute cutaneous lupus erythematosus, which is an annular appearing rash, which tends to affect the forearm, shoulders, neck, and upper torso, and discoid lupus. Now, discoid lupus are actually discrete plaques which commonly affect the face, scalp, neck, and upper torso and results in scarring. Less common manifestations also include bullous lupus, paniculatus, livedo reticularis, and urticaria. Remember, cutaneous lupus, it can occur in absence of systemic involvement. Okay, let's move on to our history. She has been feeling generally unwell with significant fatigue, but systemic review is otherwise unremarkable, including no chest pain or dyspnea, gastrointestinal or neurological symptoms. Okay, before we move on to the history, a few points I like to mention. Always ask about the photosensitivity. Photosensitivity is commonly reported in SLE, and remember, both cutaneous and systemic manifestations may worsen with ultraviolet light exposure. They may be related to sun-related cell damage, releasing increased autoantigens that are poorly cleared in patients with SLE, and they provide a stimulus for the dysregulated immune response in these patients and activation of downstream inflammatory pathways. Mucosal involvement is another common manifestations of active SLE, typically with ulcers affecting the tongue, palate, buccal mucosa, and nasal mucosa. And alopecia is common with active disease and may be scarring or non-scarring. Dry eyes and mouth, these are called Zika symptoms, which are a characteristic manifestation of Sjogren's syndromes. And Sjogren syndrome can occur as a standalone connective tissue disease, which is called primary Sjogren's, with or without extra glandular involvement, or can occur in association with another autoimmune disease, which is called secondary Sjogren's. Sjogren's syndrome actually is associated with SLE in around 15% of cases. Constitution symptoms like fever, weight loss, appetite loss, and fatigue, they are common in patients with SLE and worsen with active disease. Fatigue is actually most common constitution complaint and is often multifactorial and difficult to manage in additional to active disease. Contributing factors may include poor sleep, depression, thyroid dysfunction, iron deficiency, and fibromyalgia. So SLE, it can affect virtually any organ system in the body, and a patient can have organ involvement in any combination and sequence. New disease manifestation can appear anytime in the disease course, so it is very important to screen all the major systems for symptoms that may suggest potential SLE related involvement. Now, the symptoms like chest pain, palpitation, dyspnea, or other cardiorespiratory symptoms should prompt consideration of heart or lung involvement in SLE. The most common manifestation is serositis, which present as pleuritic chest pain. Associated effusions also can result in dyspnea and cardiac and or respiratory compromise. GI symptoms is uncommon in SLE. It is more frequently seen in Asian. And mesenteric vasculitis, serositis, and lupus enteritis, these are the possible manifestations. And there is a broad array of neuropsychiatric manifestation in SLE, which can affect both the central and peripheral nervous system. And these manifestations can be very difficult to diagnose and manage. Possible neurological presentations include seizures, psychosis, transverse myelitis, headache, and peripheral neuropathies. Other causes of these presentations require exclusion before attributing them to SLE. Okay, let's move on to other points in the history. She has never had a blood clot or miscarriage. Now, this history is important because antiphospholipid syndrome can occur as a primary entity or in association with rheumatological disease. The clinical criteria for antiphospholipid syndrome include thrombosis of an artery, like in a stroke, MI, or peripheral arterial thrombosis, and or vein, either DVT, pulmonary embolus, or cerebral sinus thrombosis, and or pregnancy morbidity, death of a normal fetus after 10 weeks, more than 30 consecutive miscarriages at less than 10 weeks, or premature birth at less than 34 weeks due to preeclampsia or placental insufficiency. Patient also need to have at least one positive antiphospholipid antibody, which can be either lupus anticoagulant, anticardiolipin antibody, or anti-beta-2 glycoprotein 1 antibody, and these actually remains positive at least 12 weeks later. So she has a history of Graves' disease on carbimazole but takes no other regular medications, and her sister was diagnosed with SLE around 3 years ago. Now, SLE is associated with a personal and or family history of other autoimmune conditions such as autoimmune thyroid disease. Now, remember, when you're taking the history, it's very important to ask about the drug history, and we should review the medications. Particularly, we are concerned about the medications that are associated with drug-induced SLE, like minocycline, TNF inhibitors, hydrolazine, methyl dopa, and isoniazid. Manifestations in drug-induced SLE are typically mucocutaneous, so we have serositis, arthritis, and cytopenia. These and neurological, well, these are less common. So mainly we have a mucocutaneous. ANA, anti-single-stranded DNA, and anti-histone antibodies are those typically associated with drug-induced SLE, and symptoms usually resolve within 6 weeks of drug discontinuation. The risk of developing SLE is increased in those with a family history. So around 10% of patients have an affected first degree family member. Although there are some rare monogenic causes of SLE, most cases have a polygenic predisposition, and over 100 genes that individually confer a relatively small increased risk of disease have been identified. And most of these genes are actually involved in the immune responses. So that's all about the history. Now let's move on to the examination. So this patient is afebrile with stable vital signs. There is tenderness but no swelling on palpation of the affected joint, and there is no joint deformity. Now the fevers can occur in up to half of patients with active disease, but infection always need to be considered. So must rule out the any acute infection. So cardiac or pulmonary involvement may lead to abnormal hemodynamics or respiratory vital signs. Hypertension may occur in lupus nephritis. Chronic hypertension should be identified and treated due to increased rate of cardiovascular disease in SLE patient. Arthralgia means pain without swelling, is more common than overt arthritis in SLE, and unlike rheumatoid arthritis, joint disease is usually non-erosive. Some patients can have overlap from forms of SLE with rheumatoid arthritis like inflammatory arthritis with joint swelling and destruction. Often these patients are rheumatoid factor and or anti-CCP antibody positive. So remember that patients with SLE can develop apparent deformities which mimic rheumatoid arthritis but are reversible and occur in the absence of joint damage or erosion. And this forms of arthropathy is called Jacquard's arthropathy and occurs mainly due to soft tissue abnormalities such as ligamentous laxity and muscle imbalance. No Raynaud's phenomena is seen. So while we examination of the hands, we should look for any Raynaud's phenomena. Raynaud's phenomena occurs in up to 50% of patients with SLE, but is a non-specific finding that can occur as a primary disease or association with other autoimmune disease. There is a malar rash over the cheeks and dry mucous membrane, but no other mucocutaneous findings. So remember that the classic butterfly rash you can see in the picture here, it is quite specific and appears as erythema and edema of the cheeks and forehead, which characteristically spares the nasolabial folds. So it is a non-scarring rash. If there is uncertainty about the appearance of rash, a biopsy can be performed to help differentiate from other causes. As I already I mentioned, the Sjogren syndrome may occur, may account for this patient dry mucous membrane, and it occurs due to inflammation of the exocrine glands. So while dry eyes and mouth are the most classic features of the condition, parotid gland also can enlarge, atrophic vaginitis and dry skin can also occur. Blood tests may show a positive ANA, usually in the speckle pattern, anti-RO-SSA and or anti-LA-SSB positivity on the ENA panel. A chronically elevated ESR, a strongly positive rheumatoid factor, and hypergammaglobulinemia. So while you're examining, you look for ulcers in the nose and mouth and for any evidence of alopecia, which may manifest as diffuse thinning discrete patches of hair loss, broken hairs or scalp rash, and these are actually plaques due to discoid lupus which results in scarring and hair loss. So once you have done the examination, you do the examination of the hand, you look at the face of the patient, and then you move on to do the heart and lung examination. So in this patient, the heart and lung examine normally, although there is mild pitting edema of the bilateral lower limbs, but the calves are soft and non-tender. Now remember, pericarditis, myocarditis and endocarditis. These are the main cardiac manifestation of SLE. And as we all know, pericarditis is usually accompanied by pleuritic chest pain, and in some occasions a pericardial rub or sign of a pericardial effusion may be present. So when you are suspecting pericarditis, look for features of pericardial tamponade such as hypotension, elevated JVP, pulses, paradoxes and muffled heart sounds. Myocarditis can present as heart failure, it can present as conduction abnormalities or other arrhythmias. I would like to mention about Liebman-Sack endocarditis. It refers to non-infectious valvular vegetation which can be complicated by valve dysfunction like regurgitation or emboli. This manifestation is more common in patients with positive anti-phospholipid antibodies. So, the most common pulmonary manifestation of SLE is actually pleuritis with associated pleural effusion, which may result in chest pain and dyspnea. Acute pneumonitis, interstitial lung disease, diffuse alveolar hemorrhages, pulmonary hypertension, and shrinking lung syndromes. These are all reported, but remember they are quite rare. Pitting edema, it can be due to cardiac involvement of SLE like constructive pericarditis or pericardial effusion or tamponade, myocarditis or valvular disease or renal disease. So, leg swelling in a patient with SLE should also prompt consideration of deep venous thrombosis given the increased risk of thromboembolism in this patient, particularly if they are positive for antiphospholipid antibodies. There is no palpable lymphadenopathy or hepatosplenomegaly. Now, hematological examination findings such as lymphadenopathy and splenomegaly, it can occur in SLE, although remember that infections, malignancy and other rheumatological conditions should be considered in the differential diagnosis when these findings are prominent. So this is all about the examination. Now let's move on to the how we will investigate the patient with SLE. So in this patient, the blood tests show a mild anemia. Hemoglobin was 10.4 and leukopenia with normal platelets. So we like to do the full blood count in these patients to look for these findings. We like to do the creatinine. Creatinine is normal in this patient. Liver functions are normal except for albumin, which is on the lower side. Now remember, the anemia may be multifactorial in SLE assessment, and the general causes like nutrition because of the iron deficiency or bleeding from the GI, as well as a cause secondary to SLE like autoimmune hemolytic anemia, aplastic anemia, and anemia of chronic disease. Anemia of chronic disease is generally a diagnosis of exclusion. A reduced white cell count, particularly a lymphopenia, is common in SLE and it can fluctuate with disease activity. Other common differential diagnoses for leukopenia with SLE are intercurrent infections like viral infections and medication-induced leukopenia because of the immunosuppressive therapies. Thrombocytopenia also can occur with active SLE, and in some cases a diagnosis of ITP may precede other SLE manifestation. So in the presence of thrombocytopenia, it is important to assess for microangiopathy, which can be organ or life-threatening and occurs particularly in association with antiphospholipid antibodies. Renal disease is the most common organ-threatening manifestation in SLE and occurs in around 30 to 50% of patients. It is crucial to screen for lupus nephritis in those with SLE, as it is often asymptomatic in early stages. Importantly, the serum creatinine and eGFR may be preserved, and abnormalities indicating renal involvement may only be picked up on urine examination. So if declining renal function is detected, this requires urgent assessment and usually a renal biopsy with rapid initiation of immunosuppression. Hepatic involvement is less common but does occur in SLE, and derangement of liver function tests may be due to medications used to treat SLE, like azathioprine and methotrexate, or it can be because of other autoimmune conditions, for example, autoimmune hepatitis, infective hepatitis, or other comorbidities, for example, fatty liver. So we have to do the renal function test, we want to do the liver function test also. Then infirmity markers, the patient has an ESR of 48 and a CRP is also elevated. So ESR actually normally fluctuates alongside the disease activity in SLE and is a useful marker for monitoring. Persistent ESR elevation despite apparent disease control should prompt consideration of chronic infection, especially in patients who are immunosuppressed, and hypergammaglobulinemia, which may be monoclonal, for example, myeloma, or polyclonal, for example, Sjogren's syndrome. Antibody test returns a positive ANA and an ENA panel positive for anti-RO antibodies. Anti-double-stranded antibodies are elevated and C3 and C4 complements are reduced. So remember, in SLE we want to do these antibodies to get our diagnosis. Now antibody tests, these are helpful for the diagnosis of SLE, but alone they are not diagnostic. If SLE is suspected clinically, we want to do ANA, ENA, anti-double-stranded DNA, anti-phospholipid antibodies, and complement should be sent in the first instance. It's quite interesting thing that autoantibodies in SLE can often be detected years before clinically apparent. The ANA is almost universally positive in patients with SLE, that is highly sensitive, but importantly it's not specific for this diagnosis. So therefore the patient who have a negative ANA can be useful in excluding SLE, but a positive ANA is not helpful in confirming the diagnosis and must be interpreted in the context of clinical findings and other investigations. So in patients with a positive ANA, ENA testing identifies the specific nuclear antigen that is the target of an autoantibody. So a range of ENA can be found in SLE. Those of most significance are anti-ROSSA, anti-LA-SSB antibodies. Remember, the anti-LA-SSB antibodies are associated with secondary Sjogren's syndrome. Anti-Smith antibodies is the most specific antibody for SLE, but it's only found in around 20% of cases. Other antibodies worth mentioning is anti-U1-RNP, which is associated with mixed connective tissue disease, which can involve SLE features, and anti-ribosomal P, which is very specific for SLE and may have an association with CNS involvement. So positive anti-RO antibodies in this patient fit with clinical pictures of Zika symptoms suggesting secondary Sjogren's. Anti-RO is also significant in SLE due to its associated pregnancy complications, which develop due to transplacental passage of maternal antibodies. So pregnant women with anti-RO antibodies requires fetal monitoring during pregnancy for congenital heart block. And neonates need to be monitored for neonatal lupus, which presents with a rash, hematological abnormalities, and deranged LFTs. A few words about anti-double-stranded DNA antibodies, where these are less sensitive than ANA, but they are more specific, around 95% for a diagnosis of SLE. And the anti-double-stranded DNA antibodies are also used to help monitor disease activity, as titers generally increase with disease activity. So the production of autoantibodies in SLE lead to the formation of immune complexes and complement activation and consumption. So complement components such as C3 and C4 are therefore reduced in active SLE, and they are useful marker of disease activity in some patients. Anti-phospholipid antibodies are negative, and urinalysis has some blood and proteins. So tests for anti-phospholipid antibodies, lupus anticoagulant, anticardiolipin, and beta-2 glycoprotein 1 antibodies is important. It's found in around 30 to 40% of patients, and they are associated with thrombosis and pregnancy morbidity. Assessment of urine is a key when evaluating a patient for possible SLE, and the urine should be monitored at regular intervals to detect the development of lupus nephritis, which may be otherwise silent until irreversible damage has occurred. Macroscopic hematuria should be characterized further with phase microscopy to determine if red cells are dysmorphic or isomorphic. If they are dysmorphic, then suggestive of glomerular hematuria as occur in lupus nephritis, while isomorphic are suggestive of lower tract bleeding. So, furthermore, in urinalysis, proteinuria should be followed up with formal quantification, most commonly with the spot urine protein creatinine ratio in the first stance, and sometimes with a confirmatory 24-hour urine collection. If significant proteinuria and or hematuria is detected, a renal biopsy is duly indicated to determine the presence and class of lupus nephritis, and obviously this will determine the subsequent management. So in the investigations, remember, we start with the simple investigations like full blood count. We want to do the renal function test, liver function test. We want all the panel of all the antibodies. We want to know the inflammatory markers, and we'll like to check the urine as well. So let's move on to the management. So in the management, I have divided the management into the short-term management and long-term. So short-term management, we obviously want to confirm the diagnosis of SLE and characterize the organ manifestation. Ensure follow-up by a rheumatologist. So the diagnosis of SLE is made based on combination of suggestive clinical features and supporting immunological findings. There is no single diagnostic test, and while there are well-known classification criteria for SLE which can be helpful, their primary role is for identifying patient for research purpose and not for clinical diagnosis. So SLE actually it encompasses a spectrum of presentation, and patients in whom SLE is the most fitting diagnosis may not always meet traditional criteria. So patients with SLE, they should be managed by a rheumatologist, and if accessible, ideally in a specialized clinic, particularly for those with complex disease. Often, other specialists are also involved in the management of particular organ manifestation. For example, nephrologists commonly co-manage patients with lupus nephritis. Coordination and communication between specialists are paramount. So in the short term, we commence hydroxychloroquine in most patients and individualize any additional immunosuppression. Now, hydroxychloroquine is actually anchor drug in SLE, and as a general rule should be prescribed in all patients unless there are contraindications. So in some patients with mild disease, it may be adequate as sole therapy. The main side effect of concern is the risk of retinopathy with long-term use, so hence the patient should have regular eye screening. So management of patient with SLE and choice of immunosuppressions, they are actually individualized according to disease manifestation, severity, and the patient comorbidities and possible side effects and medication tolerance, patient future pregnancy plans, and patient preference. aim to minimize steroid exposure, educate about sun protection and smoking cessation, and counsel about family planning. So immunosuppressive regimes for patients with SLE, they may include corticosteroids for rapid disease control or refractory disease. A range of traditional immunosuppressive agents like methotrexate, azathioprine, mycophenolate, calcineurin inhibitors, cyclophosphamide, and occasionally biological agents like rituximab. Um, these are the traditional immunosuppressive agents. So, in general principles, milder manifestations such as skin and joint disease can be controlled with hydroxychloroquine and or methotrexate. More severe manifestations like lupus nephritis, hemolysis, or severe serositis, they require azathioprine or mycophenolate. And life-threatening manifestations such as severe renal disease or CNS involvement, these are treated with cyclophosphamide. So remember that although the steroids are highly effective for controlling inflammation, prolonged use of moderate to high dose steroids is associated with significant side effects and treatment related morbidity. Steroid sparing agents should be preferably prescribed where possible. So we know that there is an association with ultraviolet exposure and disease activity. So patients should be counseled about minimizing the sun exposure and adopting sun protection techniques such as sunscreen and protective clothing. Smoking is associated with more active SLE and cardiovascular disease, and which is a significant cause of mortality in patients with SLE. So patients should be advised to quit smoking. Family planning, including contraceptive and preconception counseling, is vital in patients with SLE who are often young women of reproductive age, and the topic should be revisited at regular intervals. Considerations include thrombotic risk with hormonal contraception, timing and preparation for pregnancy, so aiming for stable disease on medications that are safe in pregnancy. Possible SLE related pregnancy risk, particularly for those with antiphospholipid syndrome and positive RO antibodies, as well as careful antenatal monitoring, usually in high level centers with specialty support. So, disease activity is monitored using a combination of clinical features and investigations which may be specific to certain organ involvement like serum creatinine and urine protein, blood testing with lupus nephritis, cytopenias with hematological manifestations, or non-organ specific, for example, ESR, complement levels, and anti-double stranded DNA. So, in the long term, we should monitor the disease activity, damage accumulation, and treatment side effects at regular intervals and adjust therapy accordingly. Institute preventive measures such as vaccination, bone protection, cardiovascular risk reduction, and cancer screening. So, damage actually refers to irreversible consequences of disease activity or treatment in SLE. Examples include like renal failure, cardiovascular events, avascular necrosis, and many other potential complications. The accumulation of damage correlates with overall prognosis, including the survival. The various immunosuppressive agents which are used in SLE have different side effects profile, and the treating doctor should be familiar with the specifics of each medication. The main issue to consider include increased infection risk and the need for regular blood test monitoring to detect derangements of full blood count, renal function, and liver functions. So, patients who have active disease or severe manifestations or heavy treatment burden, they are followed up frequently, like 1 to 3 monthly, while those with stable disease may be suitable for less regular review, 6 or 12 monthly. Remember, disease flares, they can be highly unpredictable in SLE. However, and patients should be advised to contact their treating rheumatologist if they develop symptoms of active disease between appointments. So the medications and doses, they are titrated over time based on the balance between efficacy to control inflammation, reduce symptoms, and prevent damage and toxicity. So which include the side effects and irreversible damage in their own right. Few words about the vaccination. In general, the inactivated vaccines are safe and effective in patient with SLE. Patients should be counseled about receiving influenza and pneumococcal vaccine as well as other routinely recommended immunization. Live vaccines are the exceptions and are contraindicated in patients who are immunosuppressed. Osteoporosis is a common complication of SLE itself, glucocorticoid therapy and lifestyle factors. For example, sun avoidance and reduced physical activity. Fractures are 5 times more common in patients with SLE than age-matched controls, including a significant burden of fractures in premenopausal women. So bone density screening, optimization of vitamin D and calcium, and in some cases, anti-resorptive or anabolic therapies are required. Aggressive management of cardiovascular risk factors is warranted due to excessive rates of premature atherosclerosis and cardiovascular events in patients with SLE. And control of disease activity, minimization of steroids, management of hypertension and hyperlipidemia, smoking cessation, weight optimization, and screen for and managing the hyperglycemia. These are all important aspects of overall care of patient with SLE. And finally, because of the combination of the disease and its treatment, patients with SLE, they are slightly higher risk of malignancy and should undertake age-appropriate cancer screening. Particular considerations include cervical cancer screening in women. Rates are up to 11 times higher in patients with SLE than the general population, and skin checks, in particular for those on immunosuppressive agents such as azathioprine, which are associated with non-melanomatous skin cancers. So that's a brief discussion about the management of the patient with SLE. Hopefully this presentation is helpful to you, and thank you very much, and I'll see you in my next presentation.